Hey everyone, and welcome to this explainer. Look, if you are passionate about cardiovascular health or just love uncovering the hidden mechanisms of the human body, you're in exactly the right place. Today, we're zooming in on a microscopic villain in cardiovascular disease, one that completely challenges what we thought we knew about heart attacks.
Okay, let's dive right into our agenda. We're going to look at the hidden cardiac threat, 3 mind-blowing facts regarding how it strikes, its amplified high-risk targets, and how to actually reverse the damage. Then we'll wrap up with future AI detection and exploring the full review.
Section 1. The hidden cardiac threat. It's essentially a medical mystery.
So, picture this scenario. A patient goes into the clinic, right? They undergo standard flow tests, maybe an angiogram. The doctor looks at the results and says, "Great news, your arteries look completely clear, no major blockages." Yet, shortly after, that exact same patient suffers a massive, life-threatening cardiac event. Like how? How does a heart attack happen when the pipes aren't even clogged? Well, it turns out the answer lies not in the size of a blockage, but in the microscopic structure of the artery wall itself. Enter thin-cap fibroatheroma, or TCFA for short. Think of it like a dangerous architectural flaw inside the vessel. You've got this large necrotic core, just filled with lipids and dead cells, and it's separated from the bloodstream by a fibrous cap that is literally paper thin. We're talking 65 micrometers or less. That's thinner than a human hair. When that fragile little roof ruptures, it exposes highly thrombogenic debris directly to the blood, triggering an immediate sudden clot. And this brilliantly illustrates a major paradigm shift in cardiology. The old focus, that was obstructive stenosis, treating it like a plumbing problem, looking for clogged pipes and stenting them. The new paradigm is all about plaque vulnerability. It's about hunting for these hidden, high-risk TCFA lesions that might not restrict blood flow at all, but are essentially ticking time bombs prone to rupture. Moving to fact 1, striking without warning. The stealth nature of TCFA.
Now this quote right here from the SAIMSARA review is absolutely crucial. It confirms that TCFA functions as a robust marker that predicts adverse events completely independent of how severe the stenosis is. It even persists in FFR-negative lesions. Basically, TCFA bypasses our traditional ischemia-guided paradigms entirely. It strikes exactly when standard flow tests suggest a patient is totally safe.
So what does this all mean for us? What's the main takeaway? It means that relying solely on an angiogram to give you the all clear is just no longer enough if you've got underlying vulnerabilities. TCFA is the invisible driver of major adverse cardiac events, MACE, like heart attacks and cardiac death, hiding in plain sight within what appear to be perfectly healthy open vessels.
Fact 2. Amplified high-risk targets. Who is actually most vulnerable to this?
4.65. Get a load of the staggering hazard ratio for diabetic patients. The review found that in diabetic populations with non-obstructive, seemingly safe lesions, the presence of TCFA gives them a nearly 5-fold increased risk of a major cardiac event within 18 months. 5-fold. Diabetes, particularly if glycemic control is poor, just creates an environment where these vulnerable plaques completely thrive.
And the risk compounds with your clinical history. In post-myocardial infarction populations, folks who have already suffered a heart attack, if imaging detects TCFA in non-culprit lesions, the lesion-level hazard ratio for future events skyrockets to 8.15. Past cardiovascular trauma dramatically escalates your future systemic vulnerability. Let's move to this timeline and see how this builds. The prevalence of these hidden TCFA lesions scales right alongside disease severity. So, in patients presenting with stable angina, TCFA prevalence is hovering around 24%. But during an acute STEMI, the prevalence in those arteries jumps to an astonishing 84%.
Okay, on to some uplifting news. Fact 3. Reversing the damage and stabilizing the plaque.
So, the crucial point here is that we aren't helpless. The evidence map confirms that intensive lipid-lowering therapy makes a really substantial impact. Tracking patients over 8 to 12 months on intensive statin therapy, the overall prevalence of TCFA dropped from 20% all the way down to just 7.1%. We are literally watching the regression of vulnerability right before our eyes.
And with advanced pharmacology, the results are even more impressive. Adding PCSK9 inhibitors like alirocumab to statin therapy doesn't just halt the process, it dynamically rebuilds the fibrous cap. In one study, cap thickness increased by over 200%. That is incredible. We can literally fortify the artery wall structural integrity from the inside out.
Which brings us to future detection into AI, predicting the unpredictable.
Currently, using high-resolution intracoronary imaging, like optical coherence tomography, or OCT, is our in vivo gold standard. It uses light to see inside the artery and measure that microscopic cap. But the future? For sure, the future is deep learning. AI models analyzing these OCT images are already hitting over 92% accuracy with near-perfect automation. On top of that, non-invasive CT texture analysis is starting to outperform conventional CT scans, hinting at a very near future where we can detect TCFA without ever putting a catheter inside the patient.
Looking at where the science is heading next, the review fires off 3 major future directions. First up, we need AI standardized classification to eliminate human error when measuring these tiny caps. Second, we desperately need TCFA-guided intervention trials. These would be randomized trials to test whether placing a preventative stent over a silent TCFA lesion is actually better than optimal medical therapy alone. And third, advancing multimodality non-invasive detection so we can safely screen way broader populations.
Finally, explore the full review. Dive into the evidence.
Now, what's really wild about this slide is the sheer scale. To appreciate the data we just covered, this explainer is based on the SAIMSARA scoping review, which built an evidence map synthesizing 457 original studies involving over 112,000 participants. It is just a massive, robust distillation of global cardiovascular intelligence.
The implications here for preventative cardiology are absolutely profound. So my question to you is, are you ready to dive deeper into the mechanics of the human heart? If you want to see the granular data on how everything from your kidney function to your sleep impacts these dangerous plaques, you've got to read the full SAIMSARA review. Dig into the evidence for yourself and continue exploring this frontier. Thanks so much for hanging out and learning with me today.